Thank you, everyone, for your patience. We had a couple of technical difficulties, but we're really excited to welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is Self-Monitoring of Blood Glucose, Choosing Wisely for Those with Type 2 Diabetes Not Using Insulin. This session is being recorded for nurses who are unable to participate today. Choosing Wisely Canada is an initiative, a campaign that was developed to reduce overuse of tests, treatments, and or interventions that may cause harm or lack benefit. And the Canadian Nurses Association was thrilled to develop a Choosing Wisely list in January of 2017. It was the first non-physician list, and it was entitled 9 Things Nurses and Patients Should Question. So this webinar builds on our second recommendation, and our partners at CADTH have been kind enough to present the evidence around this item. My name is Carrie Schuhendler. I'm a policy advisor and registered nurse at the Canadian Nurses Association, and I will be hosting the webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you will see to the right of the slide. We will address as many questions as time allows. And now, a little about our presenters, Stephanie Smith and Kaja Kaluzny. Stephanie Smith is the New Brunswick Liaison Officer for CADTH. A registered nurse, she holds a Bachelor of Nursing degree from the University of New Brunswick and a graduate degree in health education from Dalhousie University. She has worked in both hospital and public health settings. In her current role, Stephanie strives to increase awareness of CADTH's products and services and support decision makers' access to and use of evidence-based health technology information. Kasia is a Knowledge Mobilization Officer at CADTH, where she uses her science background and communication skills to facilitate the transfer of knowledge between researchers, clinicians, policymakers, and others involved in decision-making in healthcare. Since joining CADTH in 2010, Kasia has been working closely on the project to optimize self-monitoring of blood glucose, among other CADTH diabetes projects. And now I'll hand it over to our presenters.
Thank you very much, Carrie. So my name is Stephanie Smith, and I am a registered nurse, and I work for CADTH, as Carrie said, as its liaison officer in New Brunswick. I'm online here in New Brunswick today, and along with my colleague, Kasia Kaluzny, who is based in Ottawa, we want to thank the CNA for the opportunity to be part of their webinar series, and we'd also like to thank everyone online for your interest and for your patience in staying online throughout our technical delay. So as you know, we're going to be talking about self-monitoring of blood glucose, and in particular, the evidence that has evolved in this area as it relates to those with type 2 diabetes who don't use insulin. So we're hoping this will be an informative webinar and also provide you with some valuable insights, some resources and tools for you to consider in your own areas of practice as you move beyond today. So CADTH does adhere to authorship and contribution guidelines. So while Kasia and I are providing today's content, this presentation is based on our research report that you see referenced here, and it's also available on our website. And we'd also like to acknowledge the involvement of Jonathan Mitchell. He was working with us as a consultant advisor for the past several months, and he played a key role in organizing the logistics for this session with CNA, and he helped Kasia and I plan our presentation. He might even be online today, so a special hello and thank you to you, Jonathan. We'll move on to the next slide here, if I can. Yep, okay, so a quick slide on disclosure. Kasia and I are both CADTH employees. CADTH is funded by the federal, provincial, territorial health ministries, and we do charge application fees for the 3 programs you see listed here. So our plan for today, we're briefly going to talk about Choosing Wisely and CNA's inclusion of a recommendation about self-monitoring of blood glucose. We'll introduce you to CADTH and the research we've done in this area, and also talk about our various tools and efforts aimed at moving this evidence into practice that are also available to you as well. We'll work through a few case studies and hope to have some time for some questions at the end. So as Carrie mentioned, CNA has actively partnered with Choosing Wisely Canada to bring a nursing voice to this campaign and develop this list of the 9 things nurses and patients should question. So item number 2 on the list is related to self-monitoring of blood glucose, and you see it here on the slide. So we thought we would just read it through to be sure that everybody's aware of the full context of this recommendation before we get into our details. So the recommendation reads, don't advise routine self-monitoring of blood glucose between appointments for clients with type 2 diabetes who are not taking insulin or other medications that it could increase risk for hypoglycemia. Many studies show that once target control is achieved, routine self-monitoring of blood glucose, or SMBG, does little to control blood sugar for most adults with type 2 diabetes who don't use insulin or other medications that could increase risk for hypoglycemia. It should be noted that SMBG may be indicated during acute illness, medication change, or pregnancy, when a history or risk of hypoglycemia exists, for example, if using a sulfonylurea, and when individuals need monitoring to maintain targets, considerations that should be part of assessment and client education. So CADTH is one of the reference sources that you would see noted under CNA's Choosing Wisely recommendation for item number 2 on self-monitoring of blood glucose, which brings us to who are we and what do we have to do with all of this? So for those of you who may not be familiar with us, CADTH stands for the Canadian Agency for Drugs and Technologies in Health. We are a pan-Canadian, independent, not-for-profit agency that supports the use of evidence when making decisions about the adoption and the use of health technologies. And by health technologies, we consider drugs, diagnostic tests, medical, dental, and surgical devices and procedures. So what does the evidence say? This is CADTH's tagline, and what I have to say about this for nurses on the line today are two things. First off, I would encourage you to borrow our tagline and think about what does the evidence say in your roles of practice. It's an important question to consider regardless of your area of practice within the system. And as nurses, we're certainly in a field that is not static. It's not boring. The literature, the evidence base, and knowledge is always evolving, and things change at such a rapid pace. So it's really important for health professionals in general to routinely question what we're doing, question our own practice habits and behaviors, things that we might have been taught 5, 10, 20 years ago. It's important to stay in touch with current evidence, but also be aware of how or where we're getting our evidence. So with that being said, my second point is that I hope that you will see that CADTH can and does play an important role in providing objective answers to evidence questions related to various health technologies, including blood glucose testing. So when you want to know what the evidence says about a particular intervention or drug, I say think CADTH. Evidence is our business, and in particular, we are experts in systematic reviews, meta-analyses, and health technology assessments, which you may recall are found at the top of that traditional evidence pyramid, as they offer the highest level of evidence, providing a synthesis of the best available evidence on a given topic. We're going to hear about one of our systematic reviews today. But first off, just wanted to show you a quick slide that outlines the various programs and services that CADTH offers. The Optimal Use project we're talking about today actually falls under our Health Technology Management Program portfolio. And as you can see, we also do a whole lot more than just that. And as an aside, Kesha and I both are part of CADTH's Knowledge Mobilization and Liaison Officer program. So on to the project regarding the optimal use of blood glucose test strips. As most of you would know, monitoring blood glucose with test strips, whether it's self-monitoring or monitoring being done by a caregiver, it's a practice that has been long established in diabetes management and thought to provide meaningful benefits to patients. CADTH actually began its project on this back in 2006, and we published our systematic review and key recommendations in 2009. Certainly a lot has unfolded since that time. Our work has been shaping policy and practice, and impact is still being realized, and we're still talking about it here today. So before we move on into the details, we thought we would just get a general sense of what your understanding and what practices in your settings might be regarding some of the content that we're going to be covering today. So we have a few questions we're going to poll you on, and I believe Leah was going to bring some polls over to the screen here. There's 3 different questions, and on your end, you should be able to select a response option that you feel represents your answer for each question. So to begin with, I think we're perhaps going backwards here, but it doesn't really matter, I don't believe. So let's start. You'll see the first question that she's put on the slide or on the screen. It asks, how much were publicly and privately funded drug plans in Canada spending on blood glucose test strips each year? So thinking back to that 2006, 2010 length of time when we were working on our project. Here's another question that asks, in your own practice settings, for patients with type 2 diabetes not using insulin, is there a predetermined plan for acting on blood glucose test results? And the third question, even if they're not using insulin, patients with type 2 diabetes should routinely self-monitor their blood glucose levels to improve health outcomes. And I believe you're able to see the results of these questions that are coming in. People's responses are being displayed as they are coming in live, correctly? So we see some variations, some differences of opinions on these questions, and we're not going to get into what the correct answers might be at this time, but you should hear answers to these questions as they go through our presentation today. So you'll be able to gauge your own responses and whether or not you might want to change your response by the end of the session today. So we'll move those polls aside. Focus a little bit on why we took this project on. So in 2006, CADTH was asked by representatives from health jurisdictions across Canada to look into this topic for several reasons. One, diabetes was a growing concern. The prevalence of type 2 diabetes was increasing, as was the use of diabetes drugs and supplies, including the blood glucose test strips that were being used for home monitoring. In fact, in the 12 years leading up to our project, the overall use of test strips had increased by 250%. So that's a pretty incredible increase in that period of time. There was also growing uncertainty about the benefits of testing, or how frequently patients should test to obtain clinical benefit, and the reimbursement policies for test strips differed across the country. And actually in 2006, total spending on test strips in the Canadian publicly and privately funded drug plans actually exceeded $330 million. And by 2010, that estimate exceeded $500 million, with more than half of those amounts being spent on test strips for those who are not using insulin. So at that point, our system was actually spending more on test strips than it was spending on all oral anti-diabetic drugs combined. So in that context, yes, this is a pretty important topic to study, given that we are a publicly funded system, we have finite budgets to work within, and provinces and territories are responsible for stewarding public funds. So they wanted to explore whether this was the best use of those dollars. So was this intervention providing good value or benefit to patients, especially for those who weren't using insulin? So to explore these types of questions, I'm going to pass this over now to Kesha, and she is our team's knowledge mobilization officer for many of the diabetes projects at CADTH. So she's going to provide an overview of this project and its findings as well.
Thanks, Stephanie, and hi, everyone. So to conduct its systematic review, CADTH first established the PICO criteria to help frame its research questions. And PICO stands for the Patient Population, Intervention, Comparison, and Outcomes. So for this project, CADTH looked at type 1, type 2, and gestational diabetes. But for the interest of time today, we're only going to talk about the results for type 2 diabetes. And the intervention was SMBG compared with no SMBG and different frequencies of SMBG. And the outcomes of interest were the effect on hemoglobin A1C, health-related quality of life, patient satisfaction, long-term complications, or mortality. So CADTH performed a literature search using electronic databases such as Medline and the Cochrane Library to find relevant studies. And it included randomized controlled trials as well as observational studies. So what the review found was very surprising. So if you take a look at the top row there, this is a summary of results for adults who were using only oral drugs or no drugs. And you can see in the top row that CADTH identified 7 randomized controlled trials, which compared SMBG with no SMBG. Pooling of results from these studies showed that SMBG is associated with a 0.25% reduction in A1C from baseline. So this result is statistically significant, but it's clinically modest. And there isn't really a gold standard for how much of a reduction in A1C would be considered clinically significant. But usually when evaluating new drugs or interventions, experts will look for about a 1% reduction. So the CADTH researchers also performed sensitivity analyses and subgroup analyses. And these were done to see if any individual factors would affect these results. However, the results from these analyses were similar to that of the overall pooled analysis. So for example, a sensitivity analysis was done for good quality RCTs, And for studies where all patients used oral anti-diabetes drugs, and the results in A1C were similar to that of the overall analysis. A subgroup analysis was also done to see if A1C was affected by the intensity of education provided to patients. So this education would be about what to do based on their SMBG reading. And the results here were also similar to that of the overall pooled analysis. Also, looking at studies where patients did not take any kind of anti-diabetes drugs, so if they were managing their diabetes just with diet or lifestyle changes, the reduction to A1C was even smaller and was not statistically significant. So in summary, SMBG is associated with modest improvements in glycemic control among patients who don't use insulin. And there was little or no evidence that SMBG provides other benefits, such as improved quality of life, greater patient satisfaction, or if it reduces long-term complications, such as blindness, heart failure, or death. So CADTH also performed a cost-effectiveness analysis. And this analysis was done using the United Kingdom Prospective Diabetes Study Outcome Model. And it takes into consideration the clinical effectiveness results, which I just talked about. It was found that SMBG at a frequency of approximately 9 tests per week, so a little bit more than daily, was associated with an incremental cost of more than $100,000 per QALY gained. And QALY stands for Quality Adjusted Life Year, and it's an outcome measure that incorporates both quantity and quality of life. So just to give you an idea of what would have been a favorable result, if the incremental cost is less than $50,000, it's generally considered reasonable value for money. If it's over $50,000, it's generally considered not cost effective. So the results for SMBG is beyond this conventionally accepted threshold. In other words, daily SMBG does not provide good value for money, and this is an important consideration in a publicly funded healthcare system that has finite resources. So CADTH also performed sensitivity analyses, and the results of these were that periodic use of test strips, so 1 to 2 test strips per week, may be cost effective, or reducing the price of test strips significantly would improve cost effectiveness. So based on these findings, what did CADTH recommend? To develop recommendations, an expert review committee was convened, and it had members from across Canada. The committee consisted of core members who served for all topics under consideration during their term, and it included 4 specialist members who were appointed specifically for this project to provide their expertise in diabetes. The committee deliberated and developed several recommendations. So for adults with type 2 diabetes who do not use anti-diabetes drugs, routine use of test strips for SMBG is not recommended for most adults. And because there was a lack of evidence, women in this patient population who are considering a pregnancy may benefit from SMBG. So that was a clinical subnote that was provided based on the clinical expertise of the committee members. For adults with type 2 diabetes who are using oral anti-diabetes drugs, but again, not insulin, routine use of blood glucose test strips for SMBG is not recommended for most adults. And also here, the committee had several important notes, and they noted that periodic testing may be beneficial for patients who are using insulin secretagogues, for example, a sulfonylurea drug, for patients who are at risk of hypoglycemia, for example, if they have a history of severe hypoglycemia, and also if they work in a job where hypoglycemia could pose a danger, so for example, professional drivers or construction workers. SMBG may also be beneficial for patients who are experiencing acute illness, so for example, the flu or an infection, for patients who are undergoing changes in their medication or significant changes in routine, so for example, if they're traveling, for patients with poorly controlled or unstable glucose levels, and for patients who are pregnant or planning a pregnancy. So these are important exceptions to keep in mind. And what are the implications for policy and practice, and are there opportunities? So one of the major opportunities is to redirect some of the money being spent on test strips to other areas of healthcare where benefits to patient health could be realized. And it's important to keep in mind that a dollar spent on one thing is no longer available to spend on another thing. Data from 2012 shows that public and private drug plans in Canada spent more than $503 million on test strips in 1 year. Most of that money was spent on patients who were not using insulin. And it was estimated that if patients who don't use insulin tested less often, more than $260 million could be freed up each year for spending on other health technologies or interventions. Money is not the only thing that could be saved. There are other opportunities. For example, if patients are testing less frequently, it could save them time. It could result in less stress or pain or inconvenience. And it would free up time to focus on other aspects of diabetes self-management, like living a healthy lifestyle. So to really fully understand the context of the situation and to be able to work towards realizing some of these opportunities, CADTH conducted an analysis of the current practice and knowledge gaps, and it undertook a series of 20 focus groups, which involved patients, diabetes educators, physicians, and pharmacists, to learn about their beliefs and perceptions on SMBG and to learn about current practices. Some of the things we heard was that nearly all healthcare professionals recommend SMBG to the vast majority of their patients, and that there was limited awareness of the evidence behind SMBG. Some of the things that the patients mentioned is that SMBG helps them feel in control of their diabetes. They feel like they're able to actively manage their diabetes. But they did mention that it does cause discomfort and inconvenience in the testing, and also having to carry around the required equipment and supplies. So I'm going to pass it back to Stephanie now to talk about moving evidence into practice.
Okay, thank you, Kesha. So at CADTH, we don't simply conduct systematic reviews, write the report, and move on. We're really committed to making sure that our work has reach and ultimately impact. So we do direct a substantial amount of effort on items beyond producing science reports, and in particular, we do that through our outreach and implementation support team. So in terms of this project, we knew we had a big hill ahead of us. We fully recognized that our new guidance was a departure from historical teachings and even current practices. And in terms of nursing specifically, the findings certainly had implications across almost all areas of nursing practice, direct clinical care, education, policy, administration, and even research. So we developed a full suite of tools to help translate the new information and recommendations into more easily digested and user-friendly material. And we supported a wide range of outreach activities, all designed to reach as many levels of stakeholders and decision makers as possible. ranging from frontline healthcare professionals, including nurses and pharmacists, physicians, certified diabetes educators, to policymakers, and to the public and patients. So this slide outlines sort of some of the broad range of tactics and strategies that we used in general to get our evidence as well as tools that could help people use the evidence into the hands of those who can benefit from them. So for example, we certainly drafted newsletter articles for publication in various channels. And for instance, I had content published in the Nursing Association of New Brunswick's Info Nursing newsletter. We drafted plain language summaries, executive summaries, educational pamphlets, provided all kinds of information sessions, presentations, and exhibits at local, national, and international events, and so on. Now, the next slide gets into some more of the specifics. It provides some of the concrete examples of implementation support tools that we developed. So some of these tools were targeted more at clinicians, like the first item that you see on the left of the screen. So this is an alternate prescription pad, and it's a tool that is designed for use by healthcare providers with their patients. So the pad is designed similar to a prescription pad with tear-off sheets that could be shared with the patient. So on the one side, the side that you see here, it profiles a new recommendation across the top in green, suggesting that for most people, less testing could be possible. And then below it, it also outlines when more frequent testing may be considered to be appropriate. So on the reverse of this page, it outlines various lifestyle tips for managing diabetes that could be encouraged, like being more active, eating healthy meals, daily foot inspections, and so on. So healthcare providers could use this tool to explain the new approach to patients and also emphasize to them when they should consider more frequent testing and encourage other self-management practices. Other tools we developed were more directed toward patient education, like information pamphlets in plain language that explain the new information and what it might mean for them. And some of these tools were then adapted for use with more specific populations, like the one you see on the far right of this slide that was adapted for those in residential care settings. So all of our tools are available free to access and download from our website, and most are available in both French and English. And I believe in that web links box below, there's direct links to the various tools that we've developed, because we've only highlighted a few of them here. Now, to support the change in practice, we also developed complementary tools based on evidence to address some of the broader issues and potential concerns that would be relevant as part of overall diabetes management within this population. So we developed a Stop Hypoglycemia pamphlet that you see here on the left, targeted towards people with diabetes to help them understand hypoglycemia, recognize the signs of low blood sugar, and provided information to them on treatment and prevention. And we also developed this broader diabetes self-management action plan that you see on the right. And it's actually a 4-page booklet-style tool that clinicians and patients can use together to identify self-management goals and work toward achieving them. So with many of our tools, we were wanting to impress that concept that effective self-management of diabetes involves consideration of much more than just blood glucose results. And recognizing that, we also created this one-stop shop location on our website. And it collates all of our evidence and tools, published articles, and so on the topic of diabetes management. So you'll find all of our materials there, and we continue to populate this evidence bundle, we call it, as new topics of interest are addressed in this area by CADTH. So as we were busy developing tools, sharing our information, we were also staying in tune with the ongoing research in this area, and other efforts did unfold by other organizations, and their findings and messages were similar to what we had found. So for example, in 2012, the Cochrane collaboration published a review that corroborated our findings, and in April 2013, the Canadian Diabetes Association, which is now known as Diabetes Canada, released their updated clinical practice guidelines with new messaging that more closely aligned with CADTH for those with type 2 diabetes. So the CNA Choosing Wisely recommendation on SMBG also includes references to both of those sources within its information source at the bottom of the list of 9. And we know that the research still is being continued, and it's still reaching the same conclusions as exemplified by this randomized control trial published just in July. So CADTH did and has continued to support extensive knowledge mobilization and implementation support efforts on this project, ultimately helping to change policy and practice in many places and settings across Canada. And this slide offers a simple pan-Canadian snapshot to try to depict that. And it's by no means all-inclusive, and we acknowledge that in some cases, CADTH's work and our efforts may have been just one factor that helped or contributed to moving these items forward. But as you can see, our work has supported educational campaigns and initiatives, as well as clinical practice changes in many jurisdictions. In addition, the star symbols that you see on this slide with the letter P in them illustrate jurisdictions where policy changes have been made that involved introducing quantity limits on test strips for those with type 2 diabetes not using insulin. And many of these jurisdictions cited the CADTH evidence as at least one factor in those policy decisions, and CADTH tools were often used to support the introduction of the new policies. Now, New Brunswick was the first jurisdiction in Canada to use CADTH's new recommendations and substantial implementation support from CADTH to roll out a new provincial policy to bring its approach more closely aligned with the new evidence. And I can share a bit more detail about New Brunswick experience because I was part of the implementation team here in New Brunswick that worked toward and prepared for the introduction of this new policy, laying the groundwork, creating the awareness, and supporting related educational efforts. So New Brunswick's policy did not remove access to provincially reimbursed test strips for those with type 2 diabetes not using insulin, but it did introduce some standard quantity limits depending on the individual's circumstances. And in all cases, the policy accommodated exceptional circumstances such that additional strips could be obtained when deemed warranted for things like ongoing bouts of acute illness or a history of hypoglycemia. So the policy came into effect in April of 2013, and it also harmonized and expanded coverage eligibility. And it was accompanied by a multifaceted educational strategy. And what you see on the screen here is a New Brunswick version of CADTH's Testing for a Reason brochure. You're just seeing the front and back of it, mind you, but we actually collaborated with the Department of Health to co-brand this brochure, and it was sent to everyone in the province who was going to be affected by the new policy. We shared copies with various healthcare professionals, and it's actually available on the department's website. And we worked in collaboration with ministry staff to host provincial stakeholder information sessions, provide presentations at local conferences where we discussed the new evidence, and we also prompted consideration about some of those other opportunities that this new evidence might offer within different practice settings. And one result was that the Department of Social Development implemented the new policy within its special care homes across the province. And just 1 year later, in its 2014-2015 annual report, and you can see it online, the Department of Health highlighted that in total, the policy changes alone freed up more than $1.5 million in a single year, while at the same time enabling more clients to qualify for access to blood glucose test strips. And in addition, other initiatives were being supported. So for example, the New Brunswick government's Diabetes Innovation Fund supported the development of a train-the-trainer curriculum that was led by a local endocrinologist and a registered nurse who is also a certified diabetes educator. And they put together a great program titled Optimizing Diabetes Management for Nursing Home Residents that was then offered at various facilities throughout the province here, and it included some considerations for less frequent testing in this population. So now Kesha is going to do a little quick overview of some of the other jurisdictional initiatives.
So here we see a screen capture of the BC Ministry of Health website on SMBG. They created the website, mailed tools and posters to physicians, along with a snapshot of their prescribing history, and they delivered presentations on diabetes at educational centers across BC. In the fall of 2011, Diabetes Canada published this tool for healthcare providers to help guide the frequency of SMBG based on various situations. And this tool aligns fairly closely to what the CADTH recommendations are. Also, in Nova Scotia, a working group involving key players from across the province developed this decision tool, and it's for professionals who are caring for patients with type 2 diabetes. It was also introduced through provincial workshops and newsletter articles, as well as CME workshops. And in Quebec, in 2013, INES published this Decision Aid tool, which also closely reflects our recommendations. recently we're starting to see some impact data. In Ontario, this new publication in JAMA Internal Medicine evaluated what the effects of their policy change were. So in the 1 year since implementing a limitation on the reimbursement for test strips, they observed cost savings of $24 million, but they did not observe any worse outcomes as measured by visits to emergency rooms and hospitals for hypoglycemia and hyperglycemia events. And Choosing Wisely Canada has also published information on this topic. So 2 of their lists, endocrinology and metabolism, and also family medicine, advise against routine testing for patients who are not using insulin. And they make sure to emphasize in the smaller text below there that there are exceptions in certain cases, and these exceptions are important to keep in mind. So applying these recommendations and exceptions into practice, Stephanie's going to take you through a few case studies.
Okay. So we thought we would run through a few very basic case study examples, and we certainly recognize that many patients or clients you may see will not present quite this cleanly. Many of you may be seeing patients when they are acutely ill, and that creates a whole different scenario if you're working within hospitalized settings. But certainly these cases may be missing pertinent detail that you would ideally want to explore as well if you were embarking on this for a full, real initial assessment. But we'll ask you to play along with us just to get a high-level sense of what these recommendations mean given different scenarios, and to reinforce some key points to consider when applying these recommendations in practice. So we're going to start with Gertrude, and as you can see on the slide here, Gertrude is a 65-year-old woman. She does have type 2 diabetes, and she does take metformin, has no other comorbidities. She eats fairly healthy, regular meal times, and she walks her dog every day. We know that she has no history of hypoglycemia, and her glucose levels are stable and well controlled. So given the general assessment that we have here and the history for Gertrude and the Choosing Wisely messaging that we're talking about today, what approach might you recommend for Gertrude? We've gotten quite a few votes in already, and I would say that we agree on the approach here. But certainly, given what we know about Gertrude at this stage, ideally we would suggest to her that it wouldn't be necessary for her to continue with routine self-monitoring of blood glucose. She's very stable, but ideally we would have this conversation with Gertrude and inform her of our assessment, explain the rationale. And we would also want to advise her that she may need to consider self-monitoring in the future if she's feeling unwell or if she has any major changes in her routine, like traveling to visit grandkids out of town, or if she becomes sick, or if she has any medication changes. But it's important to get Gertrude's input as well. And it might be that the news about less testing would be very welcome and good news for Gertrude. We know that testing can create anxiety for some people who obsess about their numbers, and test strips can be costly at $1 a strip in general. That can add up, and they're not always a fully covered benefit under some health and drug plans. So this could mean some savings for Gertrude as well. But on the other hand, if Gertrude strongly feels that she wants to continue to test, and perhaps she thinks that's what's keeping her on track, and it's part of the reason that she's maintaining her targets and is so well controlled. Well, if that's her preference, then she can make that as an informed decision, or she may decide she could try to cut back a little bit and see how that impacts her targets and her levels over time. And then she may decide she could cut back some more. So it's really about having the conversations, providing the client with the information so that they can make an informed decision about self-management, knowing what it may or may not mean in their overall diabetes management and the outcomes. So we'll move on to the next case. And this is a case about Margaret, who is also a 65-year-old woman. She has type 2 diabetes. She takes metformin and glycoside, which is a sulfonylurea drug. She has high blood pressure, frequent headaches. She eats a fairly healthy diet, but physical activity is sporadic, and her sleep schedule is also a little irregular. So given this general synopsis for Margaret, do you have a sense of what approach regarding SMBG might be advisable? You wanted to take a second to add in your thoughts on this case? Well, we're right on target again here pretty much. Our approach would be that some frequent or more frequent SMBG may be advisable, given that she does take gliclazide, which is a sulfonylurea drug that is associated with a higher risk of hypoglycemia. And we're not really sure with the information we have whether this is a new drug for her or how well controlled she is at this point. In addition, her patterns don't seem to be so routine. So again, we would want to consider all of this and use our information to coach Margaret in terms of testing for a reason if she's going to test. And testing should always help determine a specific course of action. So first off, given Margaret's scenario, it would be very important that she recognizes she's on a drug that may cause hypoglycemia or has a higher risk for that. And so she needs to be aware of the potential signs of hypoglycemia, and you might want to use the CADTH tool to provide that education. And it would be important for her to test if she's experiencing any of those symptoms of hypoglycemia. And so, for instance, perhaps the next time she gets a headache, she might want to test because it could be a sign for her of low blood sugar. And she should test at times when hypoglycemia may have previously occurred, or if she's going to be embarking on any particular activity where hypoglycemia would be a risk, like perhaps joining a new strenuous physical exercise program. So most importantly, Margaret needs to know how to act upon results if she's going to be testing. And it was interesting that in previously, for the question we had up front, 70% of the respondents indicated that in their own practice settings, there's not always a predetermined plan for acting on the results. And I think one of the messages around this whole piece is recognizing that we're testing for a reason, and people need to know what those numbers might mean. And if they're not doing anything with them and it's not meaning anything, then we have to question why anybody's doing it. So in the case with Margaret, it would be important for her to understand what her reading would be, what reading might indicate hypoglycemia, and what she would need to do about it. So that would be a very important piece of the coaching with her. And of course, then depending on whether the gliclazide is new to her regimen and whether or not she's been achieving good glycemic control, more routine monitoring could be used for a period and offer some guidance and possible lifestyle adjustments in response to the blood glucose value she gets. For example, she might use the results to guide her reading and exercise decisions, and maybe on the days that she's exercising, she realizes she might need an additional snack. But if she does become quite well controlled, she could move on to less frequent testing, unless, of course, there is any cause for concern with hypoglycemia considerations or if she becomes sick. So the next example is very simple as well. Here we're talking about John, a 40-year-old, type 2 diabetes. He takes metformin, eats a fairly healthy diet, meals at regular times. He drives a truck all day for his job. So again, what approach might be advisable given what we know about John? And I might have jumped the gun here, but I see the results are coming in half-half or a little more towards routine, not required. And in this case, we wanted to emphasize the fact that in some situations, given their status, it may seem like they're fairly stable, but given the concept of occupational risk and hypoglycemia is really an important factor to consider. So in case of this case, because hypoglycemia would be especially dangerous given his occupation, some jobs do require strict avoidance of hypoglycemia. And in those cases, there are times when blood glucose testing requirements may be set by the employer. So for John, some monitoring of blood glucose might be advised given his occupation. But again, the underlying concept would be that John should be testing for a reason. So if he's on vacation for a month or he's on his weekends off and he's feeling relatively well and stable otherwise, he could reasonably opt for less or no testing, provided everything else is stable. So what you see here is a sort of a merge. One identifies at the top the CNA primary recommendation on its Choosing Wisely list regarding self-monitoring of blood glucose with type 2 diabetes. The bottom half says bottom line. That's coming from an infographic that CADTH had created on this topic. But basically, you can see that our messaging and bottom lines align. And so there's strong evidence that most people with type 2 diabetes not using insulin can self-test less often without any impact or negative effect on their health. The message is certainly to choose wisely. And if you're going to test, you should be testing for a reason, and it should be determining a specific course of action based on the results that are being achieved. So certainly the Choosing Wisely Canada Nursing List is a great way to engage nurses and patients in conversations about care. It also emphasizes our professional obligations to be responsible stewards of healthcare resources. We do need to engage in conversations with our patients and clients about what they do need, but also what they don't need. And I think it's really important that we as nurses are open to questioning our own practice habits. We know that practice habits are one of the recognized drivers of unnecessary care, and we know that traditionally they are very difficult to change, even in the face of new evidence. And we certainly experienced that with this project. So I would say to be aware of your practice habits and approaches, and remember to consider the "what does the evidence say" tagline. And remember that you can look to CADTH for answers to your evidence questions or for tools that might help you better understand or use that evidence in practice. So I think now we pass it back over to Carrie.
Great, thank you. So I'm just going to forward through some of the reference that were provided and CADTH's contact information there. And thank you so much, Stephanie and Kasia, for your presentation. So before we move on to the Q&A period, we'd like to ask the participants to answer a couple of short survey questions about today's webinar. So there's one there about if there are other people in the room with you, that just helps us to have some information about the reach of our webinars and evaluate our webinar program. And then there's also one about how likely you are to use this information in your day-to-day work. So we'll leave it open just for a few more seconds, and thank you all who are completing those. Great, thank you. So that's just some information that we'll take back for our evaluation. And then we will now start the discussion portion of the webinar. If you haven't already, please type your questions into the Q&A box so that you can see at the right of the slide. So we do have a question about someone who's asking about self-monitoring role for detecting hyperglycemia given the damage that this can cause. So I just wonder if our presenters can speak to that a little bit.
Could we hear the full question, please?
The question is just, I guess if you want to reiterate, I know the person is asking about self-monitoring for detecting hyperglycemia, knowing that having an elevated blood glucose can cause some damage. If you could just summarize what the recommendations would be around that.
But this is Stephanie. To begin, CADTH didn't make recommendations, excuse me, in particular around hyperglycemia, but certainly if there were any reasons that people would suspect that there would be a requirement to, or any symptoms that were being experienced, any change in someone's level of wellness, we would suggest that monitoring of blood glucose would be advisable, and that would incorporate hypoglycemia or hyperglycemia. And then again, knowing what the approach would be for the person doing that to follow up on based on the results that are received. I'm not sure if that's what the question was asking about, or?
Great, thank you. And then we have a question, does CADTH's project affect other aspects of SMBG best practice, such as changes to how test strips should be stored or which part of the finger should be used for the puncture site?
Hi, it's Kasia here. So this particular CADTH project really focused on the optimal frequency of SMBG, and it didn't look at the other best practices surrounding self-monitoring. So none of those would change as a result of this project. And we would encourage healthcare providers to follow best practices for that, and perhaps Diabetes Canada could be a good source of information.
Thank you. And then a question around if you can potentially compare how the Diabetes Canada current guidelines compare to the recommendations from the analysis done by CADTH.
Mm-hmm. Well, we can certainly, Kasia, we could go back to the slide here where you were showing the tool. I'll see if I can flip back to it quickly. And it's a great tool that Diabetes Canada put together to provide, let's see if I can find it quickly, and you could find it online. It's available online as well. And it certainly provides, you can see in green, yellow, and red, sort of the stoplight for self-monitoring, the caution light, and the more frequent monitoring. And of course, the top group in this table looks a lot at those using insulin, but it identifies, for instance, in the very bottom, in the C group, suggesting that daily monitoring is not usually required if a person with diabetes is treated only with lifestyle and is meeting glycemic targets or has prediabetes. And certainly in the new recommendations that have come out by Diabetes Canada, they do advise or acknowledge the fact that the evidence is less clear for those with type 2 diabetes not using insulin. But they do suggest that, I can read it to you, that self-monitoring recommendations for that population should be individualized depending on the type of anti-hyperglycemic agents, level of glycemic control, and the risk of hypoglycemia. And under a sub-note with that, they acknowledge that if people are achieving glycemic targets or receiving medications not associated with hypoglycemia, infrequent monitoring is appropriate. And there's certainly a lot more in their guidelines around this. And the Diabetes Canada website does provide some great tools, even about testing patterns or frequencies for different scenarios like acute illness or starting a new medication. And so some of the words that we use are different, but certainly that testing for a reason and incorporating blood glucose testing is part of overall diabetes management, and coaching patients with self-management is very consistent with Diabetes Canada's approach and the tools that they have available as well. Does that provide a general answer?
That's great. That's great. Thank you. And what about, can you speak to recommendations or summary of recommendations for patients who are newly diagnosed with type 2 diabetes?
Certainly that newly diagnosed population is different because they are newly diagnosed. And in some cases, there is a great opportunity for people to learn about the influence of diet and exercise on their blood glucose values. And Diabetes Canada and many organizations do suggest that first 6-month period is a good time for people to learn and to do some monitoring of blood glucose to learn from the impact of their actions or activities in their diet and sleep and stress and what that might mean for their blood glucose levels. And certainly a lot of the policies that were put in place, and the one in New Brunswick as well, allowed an allowance for test strips for those who are newly diagnosed, so that there is that opportunity to use test strips for an educational purpose beyond that 6 months or beyond that initial period of time. If that group is stable and they're doing well, they would fall into the general category of not needing to routinely self-monitor if they're not using insulin and if everything else is well.
Thank you. And in the interest of time, I know we started a little late, but so it's a little bit after 1. We'll take maybe one more question. I see several that are kind of themed around what do you mean about periodic testing? So what does the evidence say about how frequent periodic testing should be?
So periodic testing would really be specific to that individual case, and so the healthcare provider would need to use their clinical judgment in how frequent that would be. It could be 4 times a day, for example, in the morning, before meals, after meals, and it's usually a temporary frequency. For example, if a patient is sick or they're starting a new medication, they might need more frequent testing for a defined period of time, for a week or a couple weeks, until they have stable glucose levels again. And then at that point, a clinical decision would be made that, okay, now maybe it's safe to test less often. But the exact number of how many times a day testing would be needed in those certain circumstances, that would have to be determined individually on a case-by-case basis.
And this is Stephanie, and I wanted to mention, too, that there are certainly clinical experts in this field. that would know a whole lot more than this than Kesha and I, people who live and breathe this every day. And I know that here in New Brunswick, when we developed our educational pamphlet for the public, we did acknowledge and include references in there for people to tap into our diabetes education centers and Diabetes Canada. And certified diabetes educators are in every province across the country too, and they are a wealth of knowledge and live and breathe this every day and have some great insights and would be a really good resource for you to tap into in your own jurisdictions as well for some guidance if you have a particularly challenging clinical situation that might require a little more thinking or that you wanted to tap into some more brain power. They would be a good resource for you as well.
Great. Thank you so much, Stephanie and Kesha, for your presentation. We've just listed contact information. For more information, there's Stephanie's contact information, Kesha's, and mine, as well as I see CADTH reps for each of the jurisdictions. So just so everyone knows as well, sometimes we often get questions about where can you find this information later. You can access recordings of our webinars and download your certificate of participation by visiting CNA's YouTube channel. And if you haven't yet done so, you can start thinking about CNA's biennial convention, which is going to be in Ottawa, June 18th to 20th of 2018. And thank you all for your participation today. Goodbye.